Very hello to one and all. I'm Dr. Karanlata Kiro. I'm Professor of Anaesthesia at DB Pulse Institute. And I'll be talking about the anesthetic considerations for intracranial aneurysm surgeries. Now, intracranial aneurysms are neurovascular emergency situations wherein there is a spontaneous SH resulting from rupture of the intracranial aneurysm. 10 to 30% of all strokes in adult patients and almost 80% of the non-traumatic SH is because of these intracranial aneurysms. These are associated with very high morbidity and mortality, and the burden is very high despite of all the advancements made till date in the neurological sciences. It has been seen that almost 10 to 15% of these patients are not even able to reach the hospital. They die before reaching the hospital. And of those patients who are admitted, 25% of them would die within 2 weeks of admission, despite of receiving the best of medical care. 30-day mortality is for the 45% of the patients who are admitted. If these patients are left untreated, then 50% of them would have a re-rupture within 6 months of the first presentation. And it has been observed that survivors often have left with physical or functional disabilities, which have a very poor effect on the quality of life, because moderate to severe neurological morbidity is observed in 30% of the patients, and almost just around 30% of the patients would have a good outcome after the best of the management. These intracranial aneurysms are seen because the intracranial vessels have a very thin amount of muscle and elastic tissue in the tunica media. The adventitia is also very thin, because of which the intracranial vessels are at risk of developing aneurysms. And these develop more so in the branching areas because of the hemodynamic stress being the highest at these branching points. If you talk about the classification on the basis of size, they are of the small, large, and giant category, depending upon the size as mentioned. On the shape, they can be called as the saccular, the berry, or the fusiform aneurysms. And when it comes to the location of these aneurysms, 85 to 95% of these aneurysms lie in the anterior circulation, which is the internal carotid artery, the middle cerebral, the anterior cerebral, and the anterior communicating artery. And almost like 10 to 15% of these aneurysms are seen in the vertebrobasilar system. The risk factors observed are increasing age, hypertension, positive family history, substance abuse. Women are at 1.24 times more at risk of developing intracranial aneurysm as compared to men. And other conditions associated are polycystic kidney disease, Ehlers-Danlos syndrome, connective tissue disorders, coarctation of aorta, and as mentioned. These patients would come to you with a history of acute onset severe headache, and characteristically majority of them would put their words as the worst headache of my life. We term it as the thunderclap headache, and loss of consciousness may or may not be seen in these cases. And sentinel headache is, however, reported by some of the patients. Other symptoms reported are nausea, vomiting, photophobia, neck stiffness, ocular hemorrhage, and hydrocephalus. 6 to 16% of these patients would have seizures because of great clot burden and subdural hematoma. And if the ICP is very high and if there is diffuse ischemia, then these patients may even come to you in comatose state with in the state of hypertension. Apart from that, focal neurological deficit is seen in the form of sensory motor weakness. These patients can have if there's a PCOM involvement, then there could also be an isolated third cranial nerve palsy with pupillary dysfunction. For diagnosis, first of all, you have to look for the SH and then look for the search and then search for the source. Whenever such a patient comes, an immediate non-contrast CT is carried out, and this is able to detect SH in almost 85% of the patients within 48 hours of the episode. What you're looking for is the hematoma, hydrocephalus, infarct, or blood in the cisterns. If the NCCT is negative, and at the same time the patient is not having signs of raised ICP, or there is no midline shift, there is no hydrocephalus on the CT, then you can do a lumbar puncture, which would be positive for xanthochromia in almost 100% of the patients if the patient comes to within 12 hours of the bleed. After this, the next step is to look for the cause. for which the modalities are CT and MR angio, digital subtraction angiography. Information you're looking for is the cerebrovascular anatomy, the source of bleed, aneurysm location, size, shape, then the status of the collateral circulation, and if there is any vasospasm. Among these modalities, DSC is said to be the gold standard. I'm sharing here a few images of CT wherein you can appreciate the aneurysm and the SH. In this slide, as you can see, there is some amount of bleed seen in the Sylvian fissure. So probably the MCA artery is having an aneurysm which ruptured. Here you can see the blood in the peripontine basilar cistern area. And this could be because of blood in a rupture of basilar top aneurysm, or maybe a posterior communicating artery. Somewhere here might have had an aneurysm which would have ruptured. Then blood in the anterior interhemispheric region. This could be because of aneurysmal rupture of the AC or anterior communicating artery. This is a CT angio, and you can see a very beautifully demarcated middle cerebral artery over here, and you can see the aneurysm in the middle cerebral artery. Again, a large aneurysm in the ACOM, in the ACA rather. This is a DSA. This is a DSA report showing aneurysm in the anterocerebral artery. This is, again, these are all DSA pictures where you can see a large aneurysm at the end of the basilar artery. So this is a basilar top aneurysm. This is also basilar top. Let's talk about the grading system of subarachnoid hemorrhage. SH grading is done to assess the risk of surgery, prognostication, and to communicate the condition of the patient among the healthcare providers. The common grades that we talk about are Huntington-Hess, the WFNS grade, and the Fisher grade. To keep it simple, lower the grade score, better would be the neurological outcome in these patients. I'll talk about the three most commonly used in brief. This is the modified Huntington-Hess grading scale, which talks about the patient status based on the clinical presentation. So the grading is from 0 to 5, 0 being unruptured aneurysm, and 5 being deep coma or deep cerebral rigidity and or a moribund appearance. The World Federation Neurological Surgeons grading scale talks about does the grading on the basis of GCS score and the motor deficit. Then you have the Fisher grading, wherein the patient is observed in relation to the radiological appearance and the presence of blood in the CT. This is a slide wherein I've tried to show you the various SAH grade on the Fisher grading here, and you can see in Fisher grade 1 where there is no blood observed. Fisher grade 2 where there is some amount of blood is seen in the ventricles, and along with that there is vertically there is less than 1 millimeter blood observed, not major SH. This is all the cisterns are showing thick blood collection. So this is Fisher grade 3. This is Fisher 4 wherein there is blood in the parenchyma. The ventricles have blood, as well as besides the cisterns, the parenchyma and the ventricles are involved. So the complications associated with subarachnoid hemorrhage have been classified as intracranial and extracranial. Among these complications, I'd like to talk about the ones that I've highlighted here. Let's start with the vasospasm and delayed ischemic neurological deficit. This is one of the most dreaded complications of SAH, and it occurs within 3 to 21 days after the acute episode of bleeding. And it is observed that ischemic consequences remain the most severe and the common cause of death and disability in these patients. The pathophysiology is not exactly known, but it is the theories given are that blood and its breakdown products enter into the intracranial arterial wall, resulting in vasoconstriction. Other theories which implicated are the presence of inflammatory markers, free radicals, and microthrombosis, cortical spreading depolarization being other theories given. Vasospasm has been divided into 3 categories. The clinical vasospasm, which is observed in 20 to 40% of the patients, wherein the patient has confusion, decreased level of consciousness with focal neurological deficit. Speech, motor can be involved. Then there is a radiological vasospasm, which is observed in almost 30 to 70% of the patients. And although the patient would not be having symptoms, yet when you look at the arteriogram, you would see the narrowing along with film defect of the contrast. Then there is symptomatic vasospasm, where a delayed ischemic neurological deficit corresponds to the region of vasospasm seen on angiogram. and then it is said to be a symptomatic vasospasm. It is seen in 20 to 30% of the SH patients. So the diagnostic modalities, there are multiple, but what we commonly rely upon is clinical evaluation, the DSA and the transcranial Doppler. The transcranial Doppler being the most important tool for diagnosing and management of vasospasm. Whenever there is a patient, we are suspecting vasospasm, first of all, you're supposed to rule out the hydrocephalus, rebleeding, electrolyte disorder, seizures, and hypoxia. Then for management, at present, the recent guidelines recommend that there should be maintenance of euvolemia, normal circulating blood volume. There was an age-old practice of triple H therapy of hypertension, hypervolemia, and hemodilution, but it is no longer practiced because over the years it has been observed through various studies that hypervolemia and hemodilution would have their own cardiac complications. But for hypertension, there have been studies, and there is cardiac class 1B level of evidence which says that if the cardiac status permits, then hypertension may be instituted for management of vasospasm. Besides this, on the basis of BAN trial, we have a good evidence for nimodipine use in patients who have aneurysmal SAH, and it is given at the dose of 60 milligram 4 times a day to all patients of SAH for 21 days from the day of hemorrhage. Whether you have the spasm or not, all patients have to be given nimodipine. Besides that, statin, endothelin receptor, and Maxalf have been tried. Pharmacological angioplasty has been tried with milrinone and papaverine, and there have been variable results. Now, for the nimodipine, we rely on the BAN trial. This was a trial which was published some good number of years back in 1980s, wherein the Picard and et al. Had done a multi-center, double-blinded placebo-controlled trial, and they found that as compared to the placebo, the patients who received nimodipine, there was a 22% less incidence of cerebral infarction, whereas in the placebo group it was 33%. And although the angiographic improvement may not have been seen with nimodipine, it was shown that it does improve the neurological outcome by improving the microcirculation and also has other neuroprotective effects. So on this basis, there is class 1 evidence, and now all patients are receiving nimodipine. The other associated physiological complications among the cardiac, the patient has sudden catecholamine surge produced by marked vasoconstriction and accompanying increase in systemic and pulmonary blood pressure. The patient can have a stunned myocardium, neurogenic stunned myocardium, wherein the patient would complain of chest pain, dyspnea, hypoxemia, left ventricular systolic dysfunction, cardiogenic shock with pulmonary edema, and even elevated cardiac markers. Because of this, many a times these patients may land up into cardiac emergency. But of course, with a history of characteristic history of the headache, NCCT should definitely be done to rule out aneurysmal SH. 50% of these patients may have ECG changes, and these are usually benign. Takotsubo cardiomyopathy has been observed in these patients. Management for cardiac complications is supportive. Among the pulmonary, we observe 20% of the patients with SAH having impaired oxygenation. 20% of these SAH patients would have pulmonary complications, and of these, 80% would have impaired oxygenation. There could be neurogenic, cardiogenic pulmonary edema, aspiration, pneumonia can be observed. Metabolic derangements are seen in the form of derangements of abnormal glucose metabolism. Hyponatremia is the most common dyslipidemia, and these patients frequently develop SIADH or cerebral salt wasting syndrome. And long-standing cases may later come with hypopituitarism as well. For treatment of these intracranial aneurysms, the definitive is obliteration of the aneurysm. This can be done surgically by applying clipping. This is an intracranial invasive route. The other is coiling done via the endovascular route. As you can see in B, microvascular clip is applied at the neck of the aneurysm, and this way it is obliterated. Whereas A, C, D are endovascular route applied coiling procedures. In the coiling procedures, sheath is introduced through the femoral artery, and then a microvascular catheter is taken all the way up to the area, the vessel of interest under the fluoroscopic guidance, and thereby coils are released. If it is just the release of coil and obliteration, it is called coiling. If the aneurysm is packed with coils and thereafter a stent can be placed, so this becomes a stent-assisted coiling. At times, a flow diverter is passed through the area wherein the vessel has aneurysm. So this is a flow diverter. Use a flow diverter in the case of aneurysm surgery. Let's look at the two various techniques independently. Craniotomy and aneurysmal clipping has the benefit of almost complete occlusion of the neck and simultaneous removal of any hematoma. This is associated with reduced cost, and it is preferred in patients who have a large intraparenchymal hematoma. MCA being a very superficially, MCA aneurysms are commonly handled by aneurysmal craniotomy and clipping. In patients who are elderly, who have associated comorbidities, endovascular aneurysmal coiling is preferred. Posterior circulation aneurysms are difficult to reach through craniotomy, so instead of clipping, coiling would be preferred in posterior circulation aneurysms. Apart from that, it is observed that endovascular procedure are involved with less surgical injury and there is better cognitive outcome. If the aneurysm is amenable to both the types of procedures, then judgment of whether to do a coiling or a clipping is based on the ISAC trial. This was again a multi-center trial, which was published way back in 2005 in Lancet. And this particular study interpreted that in patients with ruptured intracranial aneurysms who are suitable for both treatments, endovascular coiling is more likely to result in independent survival at 1 year, which is better than the neurosurgical clipping procedures. And the survival benefit continues for at least the next 7 years. The risk of late rebleeding is also low in patients who have undergone endovascular clipping as compared to patients who have undergone aneurysm clipping procedures. Let's see how to evaluate these patients for the surgery. In the clinical presentation, look specifically for the day of ictus, the SAH grade, if the patient has any non-neurological complications, what is the volume status, what is the hemodynamic status. The investigations are routine, but apart from that, you'll also like to look for the cardiac markers. You'll like to look at this CT, the cerebral angiography, and echocardiography if required. In the pre-op instructions, all pre-op medications are to be continued unless contraindicated, and antacid prophylaxis is to be given. Nimodipine antihypertensives have to be continued. If the patient is having a good Hunt-and-Hess grade, low Hunt-and-Hess grade, then a short-acting anxiolytic should also be added to the pre-op medications. If the patient has to undergo an endoscopic procedure and coiling has to be done, then anticoagulants have to be advised as per the guidelines. The goals that we have to keep in mind while doing these procedures are avoidance of aneurysm rupture, so a strict control of the hemodynamic parameters. I'll talk about this in detail later. And then prevention of rapid fluctuation in intracranial pressure, maintaining adequate cerebral perfusion and cerebral oxygenation, reduction of brain bulk to facilitate surgical exposure and safe clipping, provision of neuroprotection at the time of clipping procedure, and rapid or smooth emergence from the anesthesia whenever planned. Let's talk about the blood pressure targets in these patients. The blood pressure target should be such that it ensures adequate cerebral perfusion pressure, but without any increase or rise in the aneurysm, without any increase in the risk of aneurysmal bleed. The aneurysmal transmural pressure gradient has a very important role to play when it comes to the risk of aneurysmal rupture. It is said to be, TPG is said to be mean arterial pressure minus intracranial pressure. So whenever there is a precipitous rise in mean arterial pressure or a sudden decrease in intracranial pressure, then this can lead to the disturbance of the balance, and there can be a risk of the aneurysm rupturing. So there are various pressure targets that have been set that we should keep in mind whenever we are managing these patients. For before occlusion, the blood pressure should be kept in the range that the patient had prior to the SAH episode, which is around 20% of the patient's normal blood pressure values. On an average, for an adult patient, this would be in the range of systolic blood pressure of 130 to 150 millimeter of mercury, or a MAP of 80 to 110. If we are not aware of the blood pressure of the patient, then a MAP of 70 to 80 or a systolic blood pressure of more than 140 may be kept. During occlusion, there is variation in the institutional practice. If an interventional radiology procedure is being planned, then the blood pressure targets are either not changed, or occasionally a decrease in the blood pressure may be asked by the surgeon. If clipping is being planned, at the time of proximal clipping, the blood pressure is usually not changed, whereas when the permanent clip is being applied, then the practice is either to decrease the blood pressure, and in some centers they may ask not even to change the blood pressure. Like in our center, the surgeons do not request us to decrease the blood pressure at the time of instituting the permanent clip. Post-occlusion, however, after embolization, the blood pressure is kept unchanged, but after clipping, the systolic blood pressure is allowed to rise to the range of 160 millimeter of mercury on a MAP of around 110. If the patient has to receive therapy for vasospasm, the ICU pressure goals are MAP of more than 80 millimeter of mercury, or till the level that the neurological symptoms decrease. Let's look at the anesthesia management protocol. For monitoring, the suggested therapeutic approach is the required monitoring would be ASA standard monitoring, the urine output, and placement of an arterial catheter for continuous invasive blood pressure monitoring. The central venous pressure, the CVP, is optional and may be decided from patient to patient as a case-by-case basis. BIS or entropy may be monitored for monitoring the depth of anesthesia and for titration of the neuroprotective agents. And if a surgeon is planning to do an intraoperative neuromonitoring, then preparation has to be done preoperative period accordingly. For the choice of induction agent, if the patient is having stable hemodynamics, or if the ICP is high, then the hypnotic agent to be chosen is propofol or thiopentone. If the patient is hemodynamically unstable, go for etomidate. Narcotics as usual. Intermediate acting muscle relaxant are used for intubation, but if this is an emergency case, then go for RSI. For maintenance of anesthesia, if the patient is having a high blood pressure, high intracranial pressure, or if there is a large hemorrhage, then TIVA with propofol is chosen. However, if the ICP is normal, you can go either for the volatile agent or the TIVA, whichever your institution accepts. We take a combination of volatile and TIVA agent if the ICP is normal. In a good grade aneurysm, the ventilation is maintained to keep a PaCO2 of 30 to 32. However, in case of poor grade aneurysm, moderate hyperventilation is given. There is no particular recommendation for IV fluids. However, go for balanced salt solution and normal saline. The other things to be kept in mind are care should be taken to prevent any sudden increase in blood pressure or sudden decrease in intracranial pressure. Noxious stimuli should be blunted. That is, whenever there is laryngoscopy or pin fixation, in those steps, the blood pressure has to be decreased by giving an additional dose of an analgesic, by applying local at the point of pin insertion, or deepening the level of anesthesia. In patients who have poor grade, remember that they would not tolerate a decrease in blood pressure because the cerebral perfusion pressure would get compromised. Then prevent hyperglycemia, hypothermia, dyselectrolemia. And for brain relaxation, the measures to be kept in mind are 15 to 30 degree head up tilt, mild hypercapnia, mannitol or hypotonic saline. And in cases who have refractory ICP, furosemide may be given. Patients who have pulmonary edema, cardiac failure, again, furosemide may be of help to us. Now, in case of patients who are undergoing craniotomy and clipping, brain protection strategies have to be kept in mind. Temporary clip is often applied proximal to the aneurysm to facilitate dissection, to approach the aneurysm, to make it more slack, and to take control of the bleeding if at all it ruptures. And during the application of temporary clip, as it is applied to a feeder vessel and not to the aneurysm as such, so the patient is at risk of developing ischemia of the concerned arterial territory. The safe duration is around 10 minutes, but if the duration increases, longer the duration of temporary clip time, higher is the risk of ischemia and infarction. So during this time, MAP should be increased to more than 90 millimeter of mercury so that blood supply can be increased through the collaterals, and neuroprotective measures in the form of the drugs mentioned may be tried. At times when the anatomy of the aneurysm is makes the temporary clip application difficult or even impossible, then a surgeon may ask you for a flow arrest. Now, this is very interesting that a transient profound hypotension would be would have to be created by administration of adenosine IV bolus. So, but in these cases, you need to be ready with a defibrillator as well. Intraoperative aneurysm rupture can occur. These can occur at the time of pre-dissection or during dissection or during clip application. A small leak, if there is a small leak, transient hypotension can be given, which may be helpful to control the bleeding, and it may provide a bloodless feel to the surgeon. But if there is a forthright rupture, then the management depends upon the hemodynamic status. Patients who have a good reserve and a short period of hypotension may be given. Adenosine flow arrest may also help the surgeon. But once the clinical features of hypovolemia set in, then the patient should be resuscitated and CPP should be maintained at all cost. In the post-op management, good grade SH patients with uneventful intraoperative course can be extubated on table, but but do take care to make the extubation and reversal process very smooth. No coughing and bucking, no blood pressure fluctuation should be occurring at the time of extubation, reversal and extubation of these patients. In patients who have a poor preoperative neurological status, and patients who had any intraoperative complication, they should be electively ventilated. Vital charting, blood sugar, serum electrolyte should also be closely monitored. Nimodipine should be started. In our setup, we have a practice of giving IV nimodipine in the immediate post-op, and thereafter, once the oral is started, we shift over to the tablet form. Prophylactic antibiotics, anti-seizure prophylaxis, and IV paracetamol are the usual post-op medication that should also be kept in mind while taking care of these patients. TCD monitoring should be done to look for vasospasm and its resolution. Other things, in patients with vasospasm, IBP and CBP monitoring should allow titration of fluids and vasopressors. The systemic sequelae of SH should be carefully looked for and managed accordingly. If there is any neurological deterioration, look urgently evaluate these patients for any electrolyte imbalance, vasospasm, hydrocephalus, or infarct. Appropriate corrective measures should be taken. The surgeon should be informed at the earliest, and surgical intervention should be taken if required. A few words about the endovascular coiling. Now, these endovascular coiling of cerebral aneurysm are carried out in neuroradiology suites, and these procedures are like any other remote care anesthesia, which have their own set of challenges for the anesthesiologist, like shifting the patient to and fro. In case of emergency, there's a difficulty. Help is far off. There is limitation of the monitoring devices, the suction machine, anesthesia equipment, etc. So a beforehand checkup should be carried out and a backup plan should be made. The anesthesia goals are safe transportation, maintaining immobility, anticoagulation, management of intracerebral catastrophes, and rapid recovery and protection from radiation hazard. Procedures undertaken are DSA coiling, intraarterial therapy for vasospasm, and preoperative workup and management remains the same as for clipping procedures. History of any allergy or contrast media or any protamine should be ruled out. If the patient has to undergo a stent or flow divert assisted coiling, then antiplatelet therapy should be confirmed prior to taking up these procedures. Radiation exposure is very high, so the adaptant and thyroid shields have to be worn. Women of the childbearing age group, pregnancy should be ruled out. Adequate measures should be taken to prevent hypothermia, as these neuroradiology suites are extremely cold and can become uncomfortable for a conscious patient. And they may even delay the recovery in case of patients who are anesthetized. Now, for diagnostic DSA or endovascular coiling, if it's a good grade, or if it's an unruptured aneurysm, then they can be carried out under sedation. Whereas for poor grade SH, patients who are uncooperative, irritable, or those who would not be able to lie down, general anesthesia may be preferred. The choice of anesthesia, the basic principles of management, and are the same. The monitoring procedure are almost as similar as you do aneurysmal clipping, as you do in an aneurysmal clipping procedure. Here also, the noxious stimuli should be blunted. And as these procedures are very long, then urinary catheterization should also be carried out. This is how a neurointervention suite looks like. Let's look at the steps of management of neurological catastrophe. You have to call for assistance, communicate to the neurologist, secure the airway, hyperventilate with 100% oxygen, and determine whether the problem is hemorrhagic or occlusive. In case of hemorrhagic complication, you would be able to see the extravasation of dye from the vessel on fluoroscopy. If the patient is conscious oriented, he would complain of sudden onset headache, nausea, vomiting. Whereas a case is, if the patient is anesthetized, you would be able to see a sudden bradycardia with rise in blood pressure. So immediately the arterial blood pressure has to be reduced by deepening the anesthesia or by use of antihypertensive agents. Heparin has to be reversed by protamine. Then patients who are on antiplatelet medications, they require platelet transfusion. A CT may have to be done, and if the extravasated blood load is very high, then EVT has to be done to prevent a precipitous rise in intracranial pressure. In case of occlusive complication, it could be because of vascular occlusion secondary to arterial thrombus, emboli, vasospasm, or misplaced catheter. Management includes increasing the blood pressure to 30 to 40% above the baseline to increase the collateral flow. IV aspirin is often administered with or without thrombolysis or abscesimab. Misplaced catheters have to be removed, and additional supportive therapy has to be given. So I would like to conclude by saying that critical events in cerebral aneurysm surgery are primarily associated with SH, and the anesthetic management coalesces around the maintenance of adequate brain perfusion and preventing rebleeding. The management can be divided as those directed towards stabilizing the life-threatening conditions, minimizing the neurological injury, and optimizing physiology and planning definitive care. Obliteration of the aneurysm by clipping or by coiling. Postoperatively, specifically targeted towards monitoring and management of vasospasm, apart from the general postoperative care given to the neurosurgical patients, and aggressive management of the symptomatic vasospasm or delayed ischemic neurological deficit. Thank you.
Thank you so much, Dr. Kiran. I can't see any questions. I don't think there are any questions in this session. And if it's okay,
thank you, ma'am.
Yeah. If it's fine, then we'll close. If somebody wants to ask the speakers anything, then only we'll continue.
And there are no questions.
No questions. So thank you so much. Yeah. Thank you so much for this. And thank you, organizers, for inviting me for this. Thank you so much.
Thank you for giving us this opportunity. Thank you.
Thank you, ma'am, for your valuable time and contribution. And thanks to both the speakers for explaining these topics in the minute details. Thank you so much.
Thank you.
So moving on with our next session, I would like to invite the chairperson for this session, Dr. Manoj Bharadwaj. Sir is Senior Consultant in the Department of Anaesthesia at Rajiv Gandhi Cancer Institute and Research Center, Delhi. Sir's area of expertise and interest are that he has worked in the field of anesthesia and critical care and various super specialties for more than 25 years and is currently working in the field of onco anesthesia from the last 6 years. and has been providing anesthesia care to robotic, assisted laparoscopic, urogynecological surgeries, thoracic surgeries, pulmonology procedures, gastrointestinal, hepatic, head and neck, and reconstructive surgeries. Sir takes special interest in difficult airway using fiber optic and video laryngoscope guided techniques in onco surgical patients. Sir has several publications in various national and international index journals and has presented papers and delivered lectures at various national and international conferences. We welcome you, sir. It's a pleasure to have you with us. I would hand over the proceedings. I would hand over the proceedings of the session to you, sir. Over to you.
Thank you. May I invite the speaker, Dr. Raj Tobin, to deliver her talk. Am I audible, Nitin? Hello?
Yes, sir, you're audible.
Yes, yes, you're audible. You're audible.
Yes. Dr. Raj Tobin, please.
Yeah.
Dr. Raj Tobin is Director and Department of Anesthesiology and Pain Management at Max Super Specialty Hospital, Saket. And her area of interest is oncoanesthesia and anesthesia for renal transplant, urology, and robotic surgery. She's a DNB examiner and instructor for CCLS,